Good evening, everyone. This is Batul from IGCP, the moderator for today's session, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned cardiologist who is here present with us today. And to talk about the topic for today, Dr. CB Patel, sir, who is our renowned speaker, who is MD, DM in cardiology, FICC, FIAMS, FCSI, FIAE, who fellow in interventional cardiology USA, visiting cardiologist at Sri Shankara Cancer Hospital and Research Center at Shankarapuram, Bangalore. So there is also a teaching faculty at the Department of Cardiology at Manipal Hospital, Bangalore, and visiting cardiologist at GM Healthcare, Ulsur, Bangalore. With such wonderful insights, we are going to talk about the topic for today, which is diagnosis and management of angina. So, before moving on to today's session, let us have a brief look on what the topic says. Diagnosis and management of angina, a symptom of underlying heart disease, involves a comprehensive approach to assessing and treating chest pain caused by reduced blood flow to the heart muscle. Accurate diagnosis relies on thorough medical history, physical examination, and diagnostic tests such as electrocardiography and stress testing. Treatment strategies encompass lifestyle modifications, medications, and in some instances, interventions like angioplasty or coronary artery bypass surgery to alleviate symptoms and reduce the risk of cardiovascular events. Please join us in this wonderful topic and to hear about it. So, we are here with us now. Without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So, over to you.
Thank you, Ankana. Thanks for this opportunity. I'm sorry for these technical problems. Can we go to the topic proper? Next slide. As you know, globally, ischemic heart disease is the leading cause of death and lost life years, less than 55 years of the age. Angina is identified initially by Haberden in 1768. Later, coronary artery disease was implicated in pathology by John Hunter and Jenner. And this word is derived from a Latin word called as a strangle. That is, angier means to strangle, a chest discomfort of a cardiac origin. Relative deficiency of myocardial oxygen supply after an activity or a physiological stress. Underlying pathophysiology being an atherosclerotic coronary artery disease and or functional alterations of epicardial vessels and or microcirculation. And of course, it needs non-invasive and invasive functional tests of coronary circulation linked to its management strategies. Next one. What is the definition of angina? A good clinical history is very important in diagnosing angina, and presence of risk factors is important to diagnose angina. It is a constricting discomfort in the chest, neck, shoulder, jaw or arms, precipitated by physical exertion, emotional stress, relieved by rest or sublingual nitroglycerin within usually 5 minutes of taking this tablet or spray. Typical angina requires all the three symptoms. Sometimes angina equivalents like fatigue, breathlessness, weakness, sweating, back or jaw pain may replace angina in females, diabetics, or elderly patients. So these atypical symptoms can be seen in elderly people or females or diabetics. Term atypical has been removed recently by the guidelines, and if meets only one criteria of the above three, then it indicates non-anginal pain. Next one. So you can see this picture wherein you can see a central, a pressure, or a squeezing, or a gripping, or a heaviness type of pain, tightness, which is usually related to exertion or mental stress, and usually it is retrosternal and typically on left-sided, maybe dully aching type. These are very typical of a severe angina, whereas sharp pain remaining for few seconds, fleeting, shifting, pleuritic type. Pleuritic means related to the our breathing. If deep breath, if there's a pleuritic type of pain, it indicates more of a pleural origin. And right-sided pain, severe tearing, ripping, burning, usually they are all unlikely in an ischemic heart disease. They indicate non-ischemic pains. Next one. So, to elaborate on this, the discomfort is often described as a pressure, tightness, or heaviness, sometimes strangling, constricting, or a burning type. The duration of discomfort is brief, usually less than 10 minutes. It will not go beyond 20 minutes. If it goes beyond 20 minutes, we have to think of an unstable angina or a myocardial infarction with sweating, vomiting, all these symptoms. The more commonly just a few minutes or less, and chest pain lasting for seconds is unlikely to be due to coronary artery disease. And it becomes more severe with increased levels of exertion. Next one. So 90% of the times the etiology is coronary atheroma itself. Rarely coronary anomalies, valvular disease like aortic stenosis, presence of a hypertensive heart disease, hypertrophic cardiomyopathy also can cause an anginal pain, vasculitis or aortitis, anemia, heterotoxicosis, all can either precipitate or can lead to anginal pain. Pathophysiology is focal epicardial obstruction may be there, epicardial vasospasm can be there, myocardial bridging can be there, diffuse epicardial coronary disease may be there, endothelial impairment can be there, microvascular dysfunction can be there. Next one. Next slide. So, what is happening is there is a narrowing of coronary arteries, either structural or functional abnormalities, that leads to insufficient blood flow, that leads to myocardial oxygen demand supply mismatch, and because of this mismatch, there's an anaerobic metabolism with lactic acid accumulation, and because of this lactic acid accumulation, myocardial nerve fibers are irritated, and pain message is transmitted to cardiac nerves and upper posterior nerve roots. That's how, in the distribution of these thoracic and cervical nerves, it leads to typical distribution of the pain of angina. Next one. Next slide. Angina with obstructive CAD, coronary artery disease, is coronary stenosis with the documented ischemia or hemodynamically relevant lesion. That is, when we call hemodynamic significant is by physiological studies like fractional flow reserve we call less than zero point 0.8, or non-hyperemic pressure ratio of less than 0.89, or more than 90% stenosis in a major coronary artery by an angiogram, invasive angiogram. Symptom guided myocardial revascularization decreases the ischemic burden as well as the symptoms also. Functional coronary disorders often overlap and can cause symptoms in obstructive CAD. Dynamic changes in lesion or a vascular tone with vasoconstriction can lead to rest angina in an obstructive coronary artery disease. Hence, other myocardial supply demand factors play a role, and both anatomy and physiology together are important to cause anginal symptoms. Next one. Ischemic threshold indicates heart rate and blood pressure product at onset of angina, and it has got again intra and inter-individual variability. Innate differences in vascular tone and endocrinal changes as they happen in menopause may also influence vasospasm. Environmental factors like cold temperature, history of exertion, mental stress are also equally relevant. A large international Clarify registry showed that overt anginal symptoms with or without ischemia was more predictive of adverse event. That means typical pain usually. So they usually indicate when they were predictive of adverse event than silent ischemia. Other factors of discordance between angina and ischemia are variations in pain threshold and cardiac innervation like diabetic autonomic neuropathy. There can be even a silent person may not feel the pain at all. Next one. So you can see these are the main factors. The systemic factors like myocardial oxygen demands mismatch, pulse rate, blood pressure products, and heightened sympathetic activation. Cardiac factors like heart failure, raised LVEDP, left ventricular hypertrophy, diastolic dysfunction, valvular heart disease like aortic stenosis, left ventricular outflow tract obstruction as in hypertrophic obstructive cardiomyopathy. They also can definitely lead to angina. Coronary is of course very important. Obstructive CAD, consider either occult diffuse coronary artery disease or even a ostial vessel occlusion. They all can lead to angina. Of course, superadded microvascular dysfunction, coronary artery spasm, myocardial bridges, endothelial dysfunction can also lead to angina. Next one. So, what is an INOCA? That is ischemia due to non-obstructive coronary artery disease. They are symptoms and are signs of definite angina, but no obstructive CAD in the anatomic or the structural abnormality. So, systemic health, psychosocial background are equally important. I have already told you heart and BP products, they are important. Myocardial supply demand ratio are relevant. Myocardial oxygen supply can decrease due to even anemia, hypoxemia. They also can precipitate angina. Microvascular angina is diagnosed by non-obstructive coronary artery disease. Reversible ischemia on functional testing is there, and coronary microvascular dysfunction by objective tests. Coronary microvascular dysfunction may be a structural, small vessel rarefaction, or increased media to lumen ratio, and functional like endothelial dysfunction also can coexist together. Next one. Myocardial bridging can cause ischemia on exercise because of vasospasm due to endothelial dysfunction underlying there. Coronary AV malformations, vasospastic angina, which is called as most often Prinzmetal's angina, is often seen in smokers, young smokers with recurrent rest angina with focal occlusive proximal epicardial artery, and usually it is manifested in the ECG in the form of a transient ST elevations during attacks. More common vasospastic angina occurs in distal and diffuse subtotal epicardial vasospasm on exertion, and usually it is manifested in the form of a ST depressions in the ECG. Both microvascular angina and vasospastic angina, they impair the quality of life, increase the mental stress due to repeated hospital admissions due to acute coronary syndromes. It can even lead to arrhythmias or heart failure also. Next one. Third factors for ischemia include, I already told in the graph, left ventricular hypertrophy, restrictive cardiomyopathy, subendocardial ischemia occurs due to impaired perfusion of arterioles penetrating deeper into the myocardium with a short diastole, enhanced systolic myocardial vessel constriction, and enhanced interstitial matrix. They also can lead to microvascular disease and dysfunction also. In heart failure, there is an increased left ventricular end diastolic pressure is there, and decreased diastolic myocardial perfusion, and that gradient increases. In aortic stenosis, hemodynamic factors cause INOCA, that is non-obstructive coronary is there, but there is a definite ischemia occurs due to aortic stenosis when symptoms and coronary flow reserve improve after the aortic valve replacement in aortic stenosis after surgery. Increased pain sensitivity and decreased pain threshold are also important, and they can lead to silent ischemia. And in two-thirds of the women with angina, most often three-fourths they present as dyspnea or other atypical symptoms, have non-obstructive CAD. Most often in two-thirds of the women, even though there is an angina or angina equivalents are there, they are most often non-obstructive CAD, and functional ischemic element is there with coronary flow reserve impairment. Next one. So this is the, so you can there are three types of causes. One is obstructive CAD, that is a more than 90% stenosis in the major coronary vessel, most often proximal or middle, and fractional flow reserve I told you less than 0.8, or a non-hyperemic pressure ratio of less than 0.9, and intermediate coronary stenosis in single major vessel with a definite documented ischemia by the test. So, what is microvascular angina? There are four factors. Most often, it requires all the four factors for its diagnosis. What is number one is symptoms of myocardial ischemia, effort and or rest angina or angina equivalents. Next is if there is no obstruction in the coronary arteries. Most often, it is a non-obstructive CAD. Why? Because the FFR, fractional flow reserve, is more ratio is more than 0.8, non-hyperemic pressure ratio is more than 0.89, and there is absence of flush ostial branch or vessel occlusions. Third, objective evidence of myocardial ischemia. What evidence should be there? Ischemic ECG changes during an episode of a chest pain should be there. Stress-induced chest pain and or ischemic ECG changes in the presence or absence of transient or reversible abnormal myocardial perfusion, or even in the echo you can see a wall motion abnormality transiently. Coronary microvascular dysfunction is diagnosed by impaired coronary flow reserve less than 0.2 or less than 2.5 depending on the methods used. Is it a Doppler derived or invasive flow, guide wire flow directed? Increased coronary microvascular resistance, that is intramyocardial reserve more than 25 or hyperemic myocardial microvascular resistance more than 2.5 millimeters of mercury. Coronary microvascular spasm defined as reproduction of symptoms, ischemic ECG shifts, but no epicardial spasm during acetylcholine testing. And coronary slow flow phenomena defined as TIMI frame count more than 25. Next one. The third type of angina is a vasospastic angina. I have already told you, most often young smokers. So there is again nitrate responsive angina, whereas there is a rest angina, especially between night and early morning, marked diurnal variation in exercise tolerance with a reduced, which is reduced in the morning. It is precipitated by even hyperventilation, and calcium channel blockers suppress the episodes, not the beta blockers. Ischemic ECG changes either ST segment elevation of more than 1 millimeter in the concordant leads. Concordant means 2-3 AVF or 1 AVL and anterior leads. ST segment depression of more than 1 millimeter or new negative U waves also indicate ischemic changes in the ECG. Coronary artery spasm, either transient total, that is more than 90% constriction if it is there, or a subtotal coronary artery of complete or a more than 90% constriction should be there with acetylcholine stimulation. And reproduction of anginal symptoms, typical pain occurs at that time with acetylcholine. And of course, I have already told you the ischemic ECG changes also can be there. So these are the main types of three types of angina. I told you main is a coronary artery disease, or it could be microvascular disease, or it could be vasospastic angina. Next one. Next slide. So, angina and the Canadian Cardiovascular Society has also got its classification. What is class 1 is presence of angina during strenuous, rapid or prolonged ordinary activity, or angina with moderate, slight limitation of ordinary activities, but still they are getting angina with mild exhaustion, that is class 3, having difficulties walking 1 or 2 blocks or climbing 1 flight of stairs at normal pace and conditions. Class 4 is angina at rest, no exertion needed to trigger angina. So you can see the severity. Class 1 is of a lesser severity, whereas 3 and 4 of they are of a more severe angina, and definitely they need further investigations and even sometimes invasive coronary angiogram itself for further management. Next one. So, in the history, family history of cardiovascular disease, less than 55 in a male, less than 65 years in a female. If they already suffered an MI or a coronary artery intervention, definitely the whole family members have to be checked. Presence of dyslipidemia is very important. LDL, when you measure, if it is more than 190, definitely it signifies. Of course, if there is a high triglycerides, low HDL, they add to it. Presence of a diabetes is equal to a coronary artery disease, and hypertension, smoking, and other lifestyle factors are also equally important. Next one. Next slide. And in the examination, check for the hypertension. Is there any aortic stenosis? Peripheral vessels have to be found out, because if there is a peripheral arterial disease, usually there will be an associated coronary artery disease and definitely endothelial dysfunction, all these things. Hypertrophic obstructive cardiomyopathy itself can lead to angina, and high BMI, because these people can have associated coronary artery disease due to the metabolic abnormalities and lipid abnormalities. And of course, waist circumference more than 80 in a female, more than 90 in a male definitely indicate that they have got a obesity and they need further evaluation for all the metabolic abnormalities, diabetes, hypertension, dyslipidemia, all these things. Next one. Next slide. Yeah. So in the investigation, complete blood count, fasting plasma glucose and HbA1c for diabetes, lipid profile I already discussed, serum creatine, because eGFR is very important. Anything below 60 ml, definitely they are at a high risk for cardiovascular disease, especially atherosclerotic cardiovascular disease. Serum uric acid test, anything more than 6 and above, definitely that also indicates that there is an inflammation in the body itself. Thyroid function test, either hyper or hypothyroidism, both can lead to and they can precipitate angina. And troponin level, just to rule out any acute coronary syndromes, all these things. Next one. Next slide. Yeah, chest X-ray is recommended for patients with a typical presentation, signs and symptoms of heart failure or suspicion of a pulmonary disease, just to rule out, of course. Next one. And if there is a pulmonary edema, it will detect. Next slide. Even in the ECG, even in typical angina chest pain, half the patient may not have any classical changes. Don't expect changes in all the ECGs. A resting 12 ADC is recommended in all patients with chest pain without an obvious non-cardiac cause. A resting 12 ADC is recommended in all patients during or immediately after an episode of angina suspected to be indicative of clinical instability. And already I have told you, a transient ST elevation is indicative of a vasospastic angina, and ST depression can be there in vasospastic angina of a distal vessels. Proximal vessels can lead to elevation. Next one. And transthoracic echo is very, very important to rule out other alternative causes like HOCM, aortic stenosis, etc. Identification of regional valvular abnormalities in the coronary territories is equally important. Measurement of left ventricular ejection fraction, and of course evaluation of diastolic dysfunction can be made out through the echocardiogram. Next. Exercise ECG is recommended for the assessment of exercise tolerance, symptoms, arrhythmias, BP response, and event risk in selected patients. Exercise ECG is not recommended for diagnostic purpose if there are already STT changes on the resting ECG. Next one. Next, stress echo. So, what are the functional non-invasive tests which are very important for IH ischemic heart disease? Stress echocardiography, single photon emission coronary tomography, that's called as PET. Similarly, positron emission tomography, that's called as PET scanning, and myocardial contrast echocardiography or contrast magnetic resonance imaging, cardiac magnetic resonance imaging are equally important. Next one. So when do you definitely suspect an obstructive CAD? What is the decreased likelihood? Normal exercise ECG, no coronary calcium by CT. Usually you don't expect an obstructive CAD in these people. Agatston score is 0 and normal exercise ECG, TMT is negative. So what are the increased likelihood are? Risk factors of cardiovascular disease like dyslipidemia, diabetes, hypertension, smoking, family history. I have already discussed all these things. Resting STD changes if they are there, even presence of a Q wave or a T wave changes also you have to investigate. LV dysfunction suggests of a coronary artery disease, abnormal exercise ECG like positive treadmill, all these things, and coronary calcium by CT. Anything more than actually any coronary calcium usually indicates a healed plaque inside the coronary artery. Definitely it is significant. Anything more than 100 indicates there is an underlying disease, and anything more than 300 definitely they need a invasive coronary angiography for further intervention. Next one. So most guidelines advocate to rule out obstructive CAD, especially in intermediate risk group by non-invasive tests like CT coronary angiogram with FFRCT and high risk groups invasively by coronary angiogram itself. So I have already told you FFRCT, anything more than less than zero point 0.8 indicates obstructive CAD. Obstructive CAD is seen in 25% of angina patients, often in men, whereas non-obstructive CAD is more common in women, where positive test for CAD is less likely to occur. If CT coronary angiogram is non-diagnostic, then stress echo, and then positron emission tomography and stress perfusion MRI are indicated. If symptoms and objective evidence of ischemia and non-obstructive CAD, then microvascular angina has to be kept in mind. If refractory symptoms and negative ischemia testing or diagnostic uncertainty, then definitely they need invasive testing for objective evidence of microvascular angina with reduced coronary flow reserve and raised microvascular resistance, severity of which determine the risk in women. Next one. If typical symptoms, negative CT coronary angiogram, non-invasive functional imaging are inconclusive, they need again invasive coronary angiogram. And if you find more than 90% proximal epicardial lesion, they need intervention. Sometimes diffuse disease and flush ostial stenosis are overlooked. Ischemia, 40 to 70% lesions are assessed. That means they are called as intermediate lesions. They are assessed using pressure-derived indices like fractional flow reserve, non-hyperemic pressure ratio like diastolic pressure ratio, or IWFR, which directs regarding interventions but do not indicate coronary vasomotion. They do not indicate vasomotion. They only indicate obstruction. Coronary microvascular resistance is directly measured by pressure or temperature sensitive guide wire by thermodilution for index of microcirculatory resistance or Doppler combo wire for hyperemic microvascular resistance based physiological assessment during adenosine induced hyperemia. Next one. So, how do you assess the microvascular disease? So, IMR more than 25 in the microvascular resistance more than 25 with reduced coronary flow reserve and unobstructed coronary artery disease has bad prognosis versus normal vascular function. So, coronary flow reserve is the ratio of maximum hyperemic flow to resting flow in absence of obstructive CAD. Normal ratio is more than 2.5, less than 2 but less than 1.6 is very critical. Reduced coronary flow reserve with normal microvascular resistance are at early stage before structural microvascular damage. And third mechanism of microvascular dysfunction is by vasoconstriction of small coronary arteries assessed by intracoronary acetylcholine. Next one. Next slide. So after ruling out obstructive CAD, pressure guide wire assessment of fractional flow reserve, IFR and IMR during adenosine-induced hyperemia. Usually adenosine is given 140 microgram per kg per minute infusion done by interventional diagnostic procedure and vasoreactivity testing performed by incremental concentrations of acetylcholine followed by a bolus vasospasm provocation up to 100 micrograms and presence or absence of diagnosis of microvascular vasospastic angina can be done by this method. Whether both are present or none can also be inferred by this test. Next one. Now coming to the our management aspect, our goals are to decrease the cardiac death, non-fatal ischemic events, disease progression, and to relieve the symptoms and its functional limitations. Next one. So we should have, along with the patient, we have to discuss, and we should shared decision making is very important. We should advise to stop smoking, avoid alcohol, stop substance abuse, treat anxiety and depression, and to avoid the mental stress, reduce body weight to optimal levels. Physical activity is very important. Meditation, yoga, relaxation exercises can be advised. Sexual health also can be advised. Minimize exposure to air pollution and smoke. Diabetes control and better drugs for diabetes control are nowadays called as SGLT2 inhibitors like EMPA and dapagliflozins, and GLP receptor agonists like semaglutide. And BP control, definitely with ACE inhibitors, beta blockers, or calcium channel blockers is equally important. And treat dyslipidemia to the target. That means if there is already existing coronary artery disease, we should target the LDL levels below 50 milligrams. Next one. Lifestyle modification and control of risk factors. I told you pharmacological management and definitely revascularization as a last if there is no relief to the medicines. Next one. In the lifestyle modification, diet high in vegetables, fruits and whole grains, limit saturated fat to less than 20% of total intake, limit alcohol, just one drink per day. Better is to avoid completely. Physical activity 30 to 60 minutes of moderate physical activity most days of the week. But even irregular activity also is beneficial. That means activity itself is beneficial. Healthy weight, obtain and maintain healthy weight less than 25 kg per square meter, or reduce weight through recommended energy intake and increase physical activity. Take medications as prescribed, and also I told you regarding the sexual activity, a proper advice should be given. Next one. So these are the first line and second line of drug, and I am also discussing the third line. In the first and second line, vasospastic angina, you need calcium channel blockers, and in the effort angina due to obstructive CAD or in the microvascular angina, beta blockers they play a role, and of course in the microvascular disease, even the ivabradine and ranolazine they help. Whereas in the vasospastic type, nicorandil and nitrates may help. And of course, to prevent the events, you need aspirin, ACE inhibitors, and high dose statins itself. Next one. So medical therapy, aspirin, I told you to prevent the events, it is very important, 75 milligrams per day. ACE inhibitors to control the and to improve the endothelial functions, statins to decrease the lipid levels and to bring it to less than 50 milligrams of LDL, and of course all other HDL has to be increased, triglycerides has to be brought down below 150. All these are very important. Both the ACE inhibitor and statins are having a pleiotrophy effects on endothelial function, and they help to improve the microvascular dysfunction also. Nitroglycerin sublingual spray or tablet for relief before activities, lifestyle modification, risk factor control like diabetes, hypertension control, patient education, and cardiac rehabilitation are important. For non-obstructive CAD, lack of high quality data for treating microcirculatory dysfunction. So still we have to go long way in the management of it. Impaired coronary vasodilator capacity, like reduced coronary flow reserve. Ranolazine has again a doubtful benefit. Ivabradine may help. Drugs to decrease myocardial oxygen consumption like nebivolol, like 1.25 to 10 milligram per day may help. Next one. Just to tell you, the beta blockers are helpful in both microvascular angina and a coronary artery disease, and bisoprolol 1.25 to 10 milligrams. and it reduces the myocardial oxygen consumption. Of course, side effects can fatigue, blurred vision, cold hands can be there. Calcium channel blockers again are helpful in all the types of angina. Dihydropyridine like amlodipine 2.5 to 10 milligram, verapamil 40 to 240 milligrams, diltiazem up to 500 milligram controlled release are helpful. They decrease the spontaneous and inducible coronary spasm via vascular smooth muscle relaxation and decrease oxygen demand, vascular muscle relaxation. And of course, they have got side effects like constipation, ankle swelling, and flushing. Vasodilators, I told you, nitrates, they help mainly in the obstructive CAD rather than, and also vasospastic angina. These two, it is going to help. Of course, it has got a side effect like headache, dizziness, flushing can be there. Nicorandil again is helpful in all the types of angina. They are 5 to 30 milligram, two times a day. Rarely it can cause dizziness. It's a potassium channel activator, nicorandil, with coronary microvascular dilatory effect. It has got side effects like dizziness, flushing, weakness, nausea. Even Rho kinase inhibitors like phosphodil can help epicardial and or microvascular spasm. Rarely, but of course it is not much available nowadays. Rashes, flushing, hypotension. Late sodium current inhibitors, and both they are helpful in microvascular angina and a coronary artery disease. Ranolazine 378 to 500 milligram two times a day, and it rarely can cause nausea, dizziness, and headache. IF channel blockers like ivabradine 2.5 to 7.1 milligram two times a day can cause bradycardia and headache can be there. Partial fatty acid oxidation inhibitors like perexilin, even trimetazidine, they are helpful in both coronary artery disease and microvascular angina, and they can cause dizziness, unsteadiness, nausea, and vomiting. Next slide. Other drugs like I have told you, ACE inhibitors, Ramipil 2.5 to 10 milligram. Rarely it can cause cough, renal impairment. It has got a lot of pleiotropic effects, decrease the blood pressure, and improves the endothelial function. Statins, atorvastatin 10 to 80 milligram per day, or even rosuvastatin 5 to 40 milligram. Better is high dose statins. Rarely can cause myalgia, headache, cramps, and hormone replacement therapy again has got a limited role, rarely, and increases risk of breast cancer, marginally increases risk of CVD. Tricyclic antidepressant, those in whom you suspect depression and anxiety, you can try amitriptyline 5 to 10 milligram or imipramine 10 to 200 milligram. Rarely they can cause blurred vision, dry mouth, drowsiness, impaired coordination. And non-pharmacological therapy, I have already told you, smoking cessation, exercise, cardiac rehabilitation, Mediterranean diet, cognitive behavioral therapy, all these things are very, very important. Next one. Next slide. Long-acting nitrates may be detrimental in microvascular angina due to poor tolerability, Steele syndrome, decreased responsiveness to microcirculation, and long-term therapy leads to endothelial dysfunction, oxidative stress via endothelium-dependent pathways. Microvascular constriction or spasm using vasodilators acting on microcirculation like CCB, amlodipine 2.5 to 10 milligram, or nicorandil 5 to 30 milligram 2 to 3 times a day. Also by improving endothelial function, by using Ramipil 2.5 to 10 milligram per day, improves microvascular tone, thus decreases microvascular spasm also. Next one. Epicardial spasm, I told you, nitrates are the basic therapy. Dual pathologies are often seen when non-dihydropyridine CCBs like diltiazem CR up to 500 milligram per day. CCBs are effective in 90% of vasospastic angina patients. And of course, I have already told the side effects, and nitrates also help, and nicorandil 510 mg BID may help in persistent vasospasm. Alpha blockers like clonidine may help in refractory cases, rule out coronary vasculitis, and few may also be helped by coronary angioplasty, also with pharmacological therapy continuation. Next one. Obstructive CAD, preferably beta blockers or CCBR are used, and if tolerated in combination also. Third line drugs are isosorbide mononitrate, 30 to 120 milligram per day, evaporating 2.5 to 7.5 milligram BID, ranolazine 375 to 500 BID, and nicorandil 5 to 30 milligram BID added depending on the comorbidities, contraindications, patient preferences, and cost, etc. Revascularization is indicated with hemodynamically significant lesions with angina refractory to medical therapy and to decrease the polypharmacy. In 1 in 5 angina, in one in 5 patients, angina may recur following PCI due to restenosis or microvascular disease. Even in asymptomatic patients with large ischemic burden, left main coronary artery stenosis more than 50%, or proximal LAD more than 70% lesion, or 2 out of 3 vessel disease with ischemic cardiomyopathy with EF less than 35%, revascularization is definitely indicated in such patients. Next one. Next slide. In patients with chronic coronary syndromes, optimal medical therapy is key for reducing symptoms, halting the progression of atherosclerosis, and preventing atherothrombotic events. Myocardial revascularization plays a central role in the management of CCS on top of medical treatment, but always as an adjunct to medical therapy without supplanting it. Revascularization by PCR-CABG may effectively relieve angina, reduce the use of anti-anginal drugs, and improve exercise capacity and quality of life compared with a strategy of medical therapy alone. Next one. A word about refractory angina. Refractory angina is more common with complex coronary artery disease like previous CABG or chronic total occlusions. Even modern day techniques have improved results of venous and chronic total occlusion interventions and have improved the prognosis and quality of life. Non-therapeutic approach to refractory angina includes cognitive behavioral therapy, stellate ganglion nerve blockade, transcutaneous electrical nerve stimulation, spinal cord stimulation, and pain modulating antidepressants like imipramine. Coronary sinus reducers also have come. Stents are there which partially reduce the venous drainage through the coronary sinus to the right atrium, so that more blood remains in the coronary veins and coronary arteries, and definitely more drainage will be there. And venous system appear promising in relieving the refractory angina patients. Next one. So just to conclude my talk, angina is often due to coronary artery disease with underlying risk factors for atherosclerotic cardiovascular disease or other structural abnormalities of heart also. Diagnosis is done by its typical symptoms. So it doesn't need, it's the typical symptoms which confirm the diagnosis. Investigate for presence of comorbidities and to be confirmed by non-invasive functional tests, and in high-risk patients by invasive coronary angiogram, and if need be by testing for coronary microvascular disease or dysfunction also. Management includes lifestyle modification with pharmacotherapy like antiplatelets, beta blockers, ACE inhibitors, and nitrates. If significant obstructive coronary artery disease, then needs revascularization along with continuation of pharmacotherapy as said above. Next one. If non-obstructive coronary artery disease is there, it also needs lifestyle modification with proper treatment of comorbidities to targets with cardioprotective drugs and continuation of antiplatelets, ACE inhibitors, statins, and beta blockers, and if need be, by adding ranolazine, nicorandil, and trimetazidine for microvascular coronary artery disease. If any other structural heart disease are present, they need treatment as per guidelines and need cardiac rehabilitation and proper follow-ups to prevent future events, to prolong the life and to improve the quality of life and to decrease the morbidity and mortality. I think with this, I conclude my talk. If there is any clarifications or any questions, rather you are welcome to ask me. Thank you.
Thank you so much, sir. Thank you for such an enriching talk that you have shared and for making our viewers understand about the topic in such a better manner. We have received few questions from the participants, so with all your due permission, I would like to put across those questions to you. So,
Definitely.
the first question is related to the key clinical features. So, what are the key
Yeah.
clinical features that differentiate stable angina from unstable angina?
I told you the stable angina is most often occurs on emotional stress or a most often physical exertion, and usually it comes on physical exertion and relieved by rest or sublingual nitroglycerin tablets or a spray. And usually, when you take an ECG at that time, it may show transient STT abnormalities in 50% of the ECGs. So, in another 50%, they may not be seen, and definitely they need further evaluation in the form of a stress, that is a treadmill exercise test, all these things. Whereas unstable angina, I told you, stable angina usually doesn't go beyond 10 minutes or 15 minutes. When such a pain continues beyond 20 minutes, then you should think of an unstable angina. If there is associated sweating, breathlessness, nausea, vomiting, severe weakness, fatigue, then you must think of a either unstable angina or he must have developed a myocardial infarction due to the heavy exertion. So this is the difference, and it will not be relieved by sublingual nitroglycerin once there is an infarct. You have to
Thank you
go
so
for further. Yeah.
Thank you so much, sir. Thank you for answering that question. We will move to the next question and the last question before we conclude the session. And the question is related to the recommendation. So, what is the recommended frequency and content of follow-ups visit for patients with stable angina?
Usually, initially, definitely you have to evaluate and confirm the diagnosis. What is the underlying risk factors? Like you must control the diabetes, you must control the hypertension to less than 130/80. Diabetes, the fasting sugar should be around 100 to 110. Post lunch sugar should not go beyond 160, 170. And of course, I have told you the drugs of choice for SGLT2 inhibitors, or if they are obese diabetics, you may have to put the GLP-1 receptor agonists. And of course, event prevention is done by aspirin and high dose statins and maybe beta blocker. And if there is a definite comorbidities, you must call him for after 1 to 2 months, reassess these dyslipidemia and other comorbidities, BP control. Again, insist on the smoking cessation if he is a smoker, and also insist on his physical activities. All these things have to be insisted each and every visit. So initially the visits could be monthly or 2 monthly. Of course, dyslipidemia has to be assessed every 3 months. Once it comes below 50 milligrams, then you can increase the little duration, but insisting on the continuation of all the treatments, including the lifestyle modification. So these are very important.
Thank you so
And
much,
if
sir.
there is
Thank you
any
for
change in the symptoms, again he must come immediately. Thank you.
Thank you so much, sir. Thank you. With this and with all your answers and with such an commendable presentation that you have shared, we would like to end the talk here for today. And I would request all our viewers to stay tuned with us for the further upcoming webinars that we have scheduled for you with some more interesting topics and with some renowned stalwarts. Thank you so much, sir. Thank you for your valuable time. We would like to conclude the
Th-
session here for today with all your last comment.
Thank you all for attending session, and I also thank the IJCP for this opportunity. Thank you, Ankana.
Thank you
Thank
so
you.
much, sir. Thank you.
Good evening. Thank you. Bye.
Good evening, sir.
Ah.